So here are just some tips when coding excision of lesions. So do not report, in addition to the lesion excision, your local anesthesia, that's included, and of course your simple closures, that is included. Now you can report, in addition to the lesion excision, any intermediate or complex repairs or reconstructive closures. And then do not report the lesion excision in addition to any adjacent tissue transfers, as the excision of the lesion is included in those tissue transfers. So burns, don't get burned with burns. Now documentation must include the percentage of the body surface. So an example, second degree burn, over 30% of the body. That depth of the burn, is it superficial? Your first degree burn, is it partial thickness? Your second degree burn, or is it full thickness, which could include or would be a third degree burn? And then again, remember your rule of nines, like we had in the ICD-9 diagnoses with burns. It's the same on the CPT side, is our rule of nines for burn for an adult or a child. And hopefully your physician should document that percentage, like we stated, of the percentage of the body affected by the burns. Now, burn CPT codes, here are most of the CPT codes for burn. CPT code 16000 is for initial treatment only, whereas 16020, 16025, and 16030 are for initial and subsequent visits. And CPT does not specify a maximum number of subsequent visits. However, a specific health plan may have a maximum number. So again, it's going to be one of those things that the billing department is going to need to know, or let the coder know in the physician's office how many, if a certain payer does have a maximum number that these burn codes can be billed and coded. Note that 16020, 16025, and 16030 state dressing and or debridement. It is appropriate to report these codes when patients are coming in specifically for dressing changes and the application of a burn product such as Silvadene cream. And you'll see that a lot in the ED when a patient comes in, maybe for a quick burn, and they apply that cream on, and the coder is going to code that burn dressing code depending on the total body surface area. These codes, of course, can be used in addition to an office visit. However, the office visit must document that it was medically necessary in order to add modifier 25 to that E&M level. So if they're just coming in only for burn treatment and they're not being seen for anything else, then you probably wouldn't have a E&M level associated with that. Now, most procedures are also known as chemosurgeries. And it's to remove a complex or ill-defined skin cancer, such as a basal cell carcinoma or squamous cell carcinoma. And most procedures are performed in stages. The first stage removes the lesion, and that specimen is divided into smaller portions called blocks. And if there's cancer cells found in a block portion, then it'll go to stage 2. Now, stage 2 further divides that specimen into blocks for further examination, and this is repeated until no evidence remains of cancer. So for most procedure, coder needs to know, in addition to the location, how many stages of each lesion the physician excised and how many blocks the physician divided. So example 17315, or an example, a patient had the squamous cell carcinoma on the tip of their nose. After prepping the patient, the physician removes the carcinoma, which is the first stage, divides it into 8 blocks for examination. Seeing positive margins, he removes to a second stage where he divides it further into 5 blocks. The physician again identifies positive margins. He performs a third stage and divides the specimen into 3 blocks, proving that it's now clear of cancer.